Okay, good afternoon. This is Andrew Bluestein, Vice Chairman of Garfunkel Wild, and I'd like to say here, but it's not really true, with my partner, Stacy Gulick. We are in separate buildings, and so bear with us as we try to do this remote technology, and we're glad that everyone has joined us to review the New York State prohibition on elective surgery. We noticed from the attendees that there are people from other states. That's fine because, as they say, coming to a theater near you. So some of the operational things that we're going to talk about will have implications for you. Jim Deering, who is supposed to be on this, he's dealing with some client emergencies out of our Albany office. So we wish him well, but we'll do the best we can. As we go through this, if you want to ask questions, put them in to the dial box that's on your screen, and we will try to answer them at the end. Not entirely sure, but I suspect that we will finish a little early because it's a narrow topic. But if you ask good questions, that'll help. Also, this prohibition, it's New York State. We know that Mayor de Blasio did one last week. This just happened yesterday. So if you want to put in, we think you guys got this wrong kind of thing, no issue. We're all learning as we go along. We have been, all of our offices have been on the phones with the various departments of health, and they're figuring out in some ways as we are as well. So welcome to this community of learning. What we're going to be doing is Stacy and I are going to be pinging back and forth, made ever more challenging given that we're not in the same room. But here goes. We're going to go to the third slide. I just want to give a little background because there's some confusion out there, okay? On March 20th, Governor Cuomo published a prior order where he said that all non-essential employees should reduce their workforce by 100%. There were some people who were taking the position, we thought wrongly at the time, and now we feel that we're more confident in our answer, that essential healthcare operations did not include ASCs. So we wanted to just spend a minute on that so that people could understand. If you look at the list of essential healthcare, and I know there's also a lot of different types of this on this phone call. There's ASC, there's hospital representatives, there's D&T. So we think it's good to keep kind of going back to this list. We keep doing it all the time. Hopefully there's nobody from the governor's office on there, but they're doing the best they can too. It was written a little ambiguously. But a hospital in New York would be considered both a D&T and an ASC. So we thought at the time that, in fact, essential businesses were not just hospitals. We now know, I think implicitly, and by the way, we also had confirmed that with the Department of Health, that it does apply to ASCs. But if you go to the next slide, I'll show you the exact definition of elective surgeries. Should come up in a second. There we are. And we've added these boldings. But obviously, if the Commissioner of Health is being authorized to direct hospitals and ambulatory surgery centers not to do elective surgery, then you obviously would know that they're deemed to be essential. But here's the order, okay? And again, for those of you who are on from other states, it's going to be copycat as this crisis grows, unfortunately. So the Commissioner of Health is authorized to direct, and so shall direct, all general hospitals, ambulatory surgery centers, office-based surgery. We've gotten a lot of questions because the original thing that order that de Blasio put out did not cover office-based surgery. So this would fix that, okay? So, and diagnostic and treatment centers, so for those of you on the phone, that applies to you too, to increase the number of beds available to patients, including, so this is not the be and end all necessarily, canceling all elective surgeries and procedures as the Commissioner of Health shall define. General hospitals shall comply with such order by submitting COVID-19 plans on a schedule to be determined. Okay, so this is very broad, and within hours of this order coming out, the Commissioner of Health issued his directive, and that was on March 23rd, so it was yesterday. So effective at the end of today, well, we're having a little trouble trying to determine exactly when it's effective. Our position is going to be safe. It's in effect for hospitals. It doesn't specifically talk about ambulatory surgery centers or anything else. In Governor Cuomo's press conference, he had said that it would take in effect in Wednesday. So that's a difficult thing to tease out. But we're going to take the position that it's today, at the end of today, it's in effect for canceling. Do I think that if you had somebody scheduled and they're all prepped and it happened tomorrow, that the world is going to end? I do not, but that's not official guidance. That's just being realistic. Okay, so when the Department of Health, the Commissioner, reiterated his ban on elective surgeries, the question, and Stacy's going to get into this in more, what is an elective surgery? We had a prior webinar, and it was hard. Everyone says, oh, I know what an elective is, but do you really know? So what was attached to the directive that came out by the Department of Health was CMS Guidance, which Stacy is going to go through, but it helps you define what could be postponed, what should be postponed, what shouldn't be postponed. So that will take up some of our time. Now, for those of you in other states, I would tell you that everyone's, I think, going to adopt these guidelines. They're interesting, and so that's the story on that one. Now, on the last point I want to make, especially for the hospitals, well, actually for everyone on the call, you guys got to all be talking to each other. We're going to make this point again, but in the directive issued by the Department of Health, they required hospitals, I mean, it's an odd way to say it, I require you to consider entering into letters of intent. But those letters of intent should be, I mean, even if they're just quick emails, I don't know that have to be anything elaborate given the time and the crisis. But I know that the hospitals, we were on the phone today with some hospitals, they're coming up with their surge plans that are due. I think there's a lot of interest. The ASCs we've spoken to, and the D&Ts as well, I haven't really spoken to many OBSs. There is a real desire to collaborate. People see the importance of this, and they want to get together. And so really encourage that. I know it's hard because the dialogues, there's like 9,000 things going on at once, but you really have to have the dialogues. Okay, what happens if you just decide, you know what, catch me if you can, putting aside all the moral issues that would involve. The executive order was quite clear, okay? If a hospital, an ambulatory surgery center, or an office-based surgery practice, or a D&T fails to comply, they'll be subject to civil penalties and the revocation of their operating certificate or licenses, okay? So if you're wondering what the actual civil penalty is, given that this came out yesterday afternoon, we did not research that. But that really should not be very motivating or inhibiting to you, because you could you could be out of business. They'll take away your operating certificate. And I think given all of the tension and anxiety in the world, you do not want to, especially right now, tempt any Department of Health, but especially the New York one, to see what their tolerance is. So we're going to tell you some things as we do this to make it a little more protective of your institutions. So with that, I'm going to turn it over to Stacy to talk about what is the key definition, which is elective. Stacy?
Hi, everybody. So since Mayor de Blasio came out with his decision to ban the elective surgeries in New York City, we have been swamped with questions as to what is elective. We've researched a lot of definitions, and it's good that the governor's office and the DOH pointed us to the CMS guidance. But we're going to provide you some others that we have seen to get a better sense of what is elective. And it's clear, even in the CMS guidance that we're going through, that this is determined on a case-by-case basis. There may be a healthy patient, a generally healthy patient scheduled for some type of procedure that you say, hey, that type of procedure we can hold off, that colonoscopy or what have you, we can hold off for 2 months. This is just routine, versus a person who's bleeding or demonstrates other symptoms and is older, may say we really need to get this procedure done. So it's not that you can classify procedures precisely as being elective. It has to be on a case-by-case basis. Also, we think that there's a lot of issues to be weighing in this decision as you go forth. It's not easy, and it's not objective. It's black or it's white. It's all levels of subjective. So you have to think, well, what's the malpractice implications if I decide to cancel this procedure, and then something goes wildly awry with this patient, versus the penalties we could face from the governor's office, versus the ethical issues. And we're not here to judge. We know this is tremendously difficult. Some doctors are saying, there is no way I'm going to bring an 80-year-old patient into an ASC because their exposure is too great. So we realize that this is a real balancing act. Interestingly enough, in New Jersey, they just made the same edicts regarding elective surgeries, and we found that they actually published a definition of elective, and their definition was that any surgery or invasive procedure that can be delayed without undue risk to the current or future health of the patient as determined by the patient's treating physician or dentist. Is really a nice, concise kind of definition. We're going to talk next about the CMS guidance, but we thought in general this is a pretty nice decision. And we are going to emphasize to the ambulatory surgery centers and not so much the OBS and the D&T centers, this is really a decision that the patient's physician needs to make. This is a clinical decision, and we're going to recommend that be documented in the future. But so it's important to kind of have a framework for what is elective. So let's look at this, the CMS guidance here. If you'll see the left hand, the far left hand one is the action, and then the definition that would lead to this action. That's really what I'm going to focus on. So they recommend strongly your tier 1. You can postpone a surgery procedure that's low acuity. It was supposed to be an outpatient surgery, not life-threatening. They're thinking about things like carpal tunnel release, EGD, colonoscopy, cataracts. Obviously, if the colonoscopy is not for some other acute problem, it wouldn't fall into this category. But generally, those are the types of examples of things you definitely are going to postpone. In addition, they have the postpone, they think even for unhealthy patients, again, taking into consideration all the totality of circumstances, it's a low acuity surgery, unhealthy patients, something like an endoscopy. Then we get a little more acute going down the cascade, and here's where you're considering postponing but don't necessarily have to, are those intermediate acuity surgeries, a healthy patient, but there's a potential for future morbidity and mortality if it's postponed. This would be something like low-risk cancer, non-urgent spine, ortho including hip and knee replacement, elective spinal surgery, stable I'm not even know how to say that word. So for these, you probably want to postpone them, but you might consider doing them if necessary. Then we get to the next tier, postpone surgery if possible. So once again, now we're a little more leaning towards actually doing the procedure. It's an intermediate acuity, unhealthy patient. They didn't even give us examples of that, so I didn't want to add any. So then we get to those that we really should not postpone. High acuity surgery, healthy patient, usually these are done in the hospital, transplants, trauma, cardiac, limb-threatening vascular surgery. Obviously, these procedures need to be done. And then we get the high acuity surgeries with unhealthy patients. Those are, again, kind of the same examples. So we can see where the government's head is a little bit. You know, the lower acuity cases are those that they're considering to be elective. As we get more and more threat to the patient, those are the ones that we want to move forward and actually do. So with that in mind, Andrew is going to talk a little bit about how we operationalize these concepts.
Thanks, Stacy. Now, we're not medical providers, so recognize that that's guidance, and you're in the weeds. So what you have to really do, and Stacy mentioned this, and we're going to pick up on this, is we really have to shift the burden to the people who are the physicians of these particular patients. But in order to do that, you know, especially now where people are so distracted trying to keep up with what's happening, you really have to communicate to your staff, and if it comes from the policy of the board, that's fine, but it really needs to be communicated, okay? And what exactly are you going to communicate? You could just take the order, you take the slide that we gave you, and, you know, this is what it is, and require physicians to provide written confirmation of non-elective status. Now, we were debating, you know, can let's say the center just do it for themselves? And the answer is no, because it needs to be somebody who, a person, not an organization necessarily, that needs to make that decision. We came up with what a very simple form, and it's funny, when we came up with this form, when we did the Mayor de Blasio thing, and somebody sent it to me and said, look at this form that everyone's using. So I'm glad, but this is not a form that was given by the government. This is Stacy and I quickly throwing something together. The purpose of the form is to protect the institution, that the decision was made that this particular patient was not elective. So somebody said, well, do we need one for elective? And the answer is no. If going forward you're going to do a procedure, you need, for each procedure that you do, you are going to need one of these forms, okay? So we just tried to make it simple, and we can debate, hopefully when this crisis is over, whether there should have been more here. But you put the patient's name, date of birth, the scheduled procedure, and then the physician is just saying, I'm aware that due to COVID-19, executive order has been issued requiring hospitals and ambulatory surgery centers to cancel or postpone elective procedures. And I have evaluated the above referenced patient and have determined that in my professional judgment, the risk of the patient that would result from postponing or canceling the procedure is such that the proposed procedure is not elective. Now, what I would also say is that when you send whatever communication, say, here's the forms, can you do this? I would send them also the slide of the CMS guidance that Stacy went through, because we've had three types of phone calls. The doctors who were saying, if I say it's elective, it's elective. Not exactly. The ones who were saying, I don't know how to make this determination. And the third, which are asking really nuanced, good questions, which are the ones that Stacy just kind of came through. What about if the patient's unhealthy versus they're healthy on a particular procedure? So give them that background. We played with attaching it, but we're trying to make it non-complicated. Sign this, stick it in the medical record, do the procedure, and go forward. Now, what if the Department of Health, who's got a lot more things to worry about right now, said, well, Andrew Bluestein, that procedure really was elective, and they disagree. If they got in the weeds at some point in the future, I'd be surprised. But this form, it's just saying that the physician made the call, and it's in his judgment. You'd have to really show that he was doing something totally irrational. Now, I will tell you that what is making us nervous, and we've had a couple of calls where doctors seem to just be saying, the hell with it, I'm going to do whatever I want to do. And as Stacy said, no judgments, but staff is not going to appreciate that. They see what's going on. I think that there is significant chance that somebody would call up DOH and make a complaint. I don't think it'll be Wednesday. It could be a week from now, especially as things get more tense. And I think the DOH would love to make a example of somebody. So I think you really want to be careful because there are just too many eyes out there and too many people are tense. And, the receptionist, the nurse, let's say, who's doing a cosmetic procedure is not going to appreciate it. No matter how much they tell you, oh, don't worry about it, don't run that risk, because as we said, you could lose your operating certificate. Okay, let's keep going. So first of all, and New York City is a little ahead of the rest of the state. You don't want to just start canceling. And I'm going to show you another form that we think is useful. You don't want to just start canceling, because then when this crisis will end, and it will end, it has to end, then you'll be like, okay, who did I postpone for a week? And realize that it's canceling. It's not necessarily postponing. Just go back for 1 second, Stacey. Yeah. So before we show you the form, when you make these phone calls, excuse me, when you make these phone calls, you want the person calling the patient to say very clearly that if the condition worsens or they have significant pain, they should call back. I don't want to be in a situation where somebody says, well, they canceled the procedure and they're getting worse and worse and worse, and they think they can't call you back. That cannot happen. And I would also probably, and we're going to go, not right now, but we're going to go to show you a log. I would have these rules kind of clipped to the log so that people use it like as a script. Okay. Now, also, you want to put the emphasis on the patient themselves to call you back on a specific date to talk about rescheduling, assuming again that their condition didn't worse or their pain didn't change, worsen. So you got to put the emphasis on them. Somebody asked when we did the last one in the city, well, what happens if they don't call you back? I don't know that that's much different than when you tell somebody, come in 2 weeks for this test, and they don't come back and they sue you for malpractice. As long as you can show, like on the medical record, told them to call back, you should be able to defend that. And then it's also important to implement precautions to protect patients and staff when people do come in. And Stacy will be talking about that a little more. All right, so let's take a look at our overly simplified callback log. And you'll see patient Smith, they were having an ACL repair. I was told by somebody who's actually on the phone that those are not necessarily things that can't be postponed. And you want to write the date it was scheduled. The callback date, again, that's when you tell the patient to call you back. And then the last column will just kind of be left there, but using this simple tool, let's assume that all of our prayers are answered and that X date from now, broke the curve and everyone's going back to normal, well, then you will have something to go back to the call log and say, all right, patient Smith was supposed to call back on April 23rd. It's now May 5th. What happened? They didn't call. So you call patient Smith, you reschedule, and so this way you'll have, and what this would look like, if patient Smith was going to sue you, it would show that there was a date they were supposed to call back, and also, though, you're going to have to follow up, because if you're recording when they're supposed to call back, I think the onus starts to move to you to find out why they didn't call back, because you now have a record of it. Okay, so with that, I'm going to hand the mic back to Stacy, who's going to take us through precautions.
So many of these things you guys have probably heard ad nauseum now. I'm sure it's like saying wash your hands, some of these things, but let's just, beat a dead bush and make sure you guys are aware of all the precautions you should be taking if you decide to move forward with doing non-elective procedures. Obviously, you want to pre-screen all patients for symptoms of high-risk exposure prior to their visit. That means have your doctors do this and all their pre-screening calls, all the scheduling calls. Every time you interact with the patient, ask them if they have any high-risk, cough, fever, traveled, been exposed to anyone with COVID. This one's really important. Even with all those interactions, tell the patient that if they start demonstrating any of the symptoms of COVID-19, that you want the patient should affirmatively call the surgery center to decide what to do. Upon arrival, but prior to admitting the patient, you want to, once again, want to ask them the questions, any indications of symptoms, that type of thing. Ask also if they've had any contact with confirmed cases of COVID-19, check their temperature. I think to the extent possible, you should not, this one's different. And if you have anybody, patients, family members accompanying the patients, staff, anyone, vendors, they should not be coming into your facility if they demonstrate elevated temperatures or any of the symptoms suggestive of COVID-19. We're all being hypersensitive to these things these days, and we have to be careful. You really want to limit visitors who are accompanying the patients. Some patients are more impaired than others. But to the extent possible, visitors should not be waiting in the waiting room. Send them out of the building. They shouldn't be waiting there. They should come back to pick up the patients when the patients are done with their procedures and ready to go. You want to allow them to either interact with the patients through all the telehealth things we're doing right now. If they have phones or pads, recommend that they keep in touch with the patient and or the physicians or the nurses via those means rather than hanging out in the surgery center. You want to have a lot of supplies that we're all worried about these days. Alcohol-based hand rub if you can get it, frequent hand washing. People waiting in cars, even if you have a lot of space, I think is a better option. Certainly if you have stuff laying around, usually to entertain visitors, take them away. We don't want visitors and we don't want stuff where germs can reside. So we'll just get rid of them all over. And obviously, the big struggle that everyone's dealing with is you want to make sure that your staff have appropriate PPE and conserving PPE, only allowing people into the operating room who are necessary to be present for the cases. I've mentioned before that for the visitors, you want to have alternate means of communicating with the patients while they're not sitting out there. And you want to consider following up with patients 7 to 14 days, which you probably do anyway because there's a lot of accreditation standards for that type of thing. But you do want to follow up with them to see if they start to develop any symptoms of COVID-19. It's always best to be informed as to what you might be facing. And as always with your staff, you should be following the CDC guidelines regarding staff not coming to work if they're displaying symptoms and all the other guidance put out by the CDC, which I'm sure you guys are very aware of. With that, we're going to finish up with Andrew. Thank you.
Okay, so by the way, now would be the time to put the questions in. Okay, so miscellaneous issues that we've had. Again, dialogue between hospitals and ASC. Quite frankly, we're seeing some of the dialogue, but we're not seeing it actually coalesce as much as we think it should be, into kind of written forms, but I think that needs to happen. And it should really say dialogue between hospitals, ASCs, and D&Ts, because there's a lot of opportunity there. Communicate the policy to staff, however you think is best to do that. Now, HR concerns. We are being bombarded by those questions, unfortunately, laying people off, limiting hours, cutting compensation. That's not the scope of this. If there comes a time where those rules stop changing every 50 seconds, we will put on another webinar. But they are changing constantly, as well as the rules on telemedicine, as well as the rules on the different sources of loans that you can get. So that's not what we're doing here. By the way, there is a webinar tomorrow, which is almost fully subscribed on telemedicine, so if people want that. And supplies. We know that supplies are a real issue, and there seems to be a little concern that if hospitals and ASCs talk to each other, the ASC supplies, for example, are going to get snapped up. We think that's misplaced, but it is possible that the state could go ahead as things get worse and just take things. So let's go to special considerations. This has come up just in conversations with clients. One is pain management. Now, somebody was taking the position that basically all pain management is considered to be non-elective. We don't share that. Again, we are not providers. I think there are some pain management issues that could be postponed. As one physician also said, bringing an 80-year-old person for a shot in her knee is not the same thing as necessarily bringing a 50-year-old person. So I think pain management has to go through the same process of the difference between elective and non-elective. Now, continuing to monitor the evolution. If I hear one more person say that in 2 weeks things are going to get worse than they are now, it's very stressful. But if things get really bad, then if you think about Stacy's list that she went through, then the risks of bringing an unhealthy patient may move some things which were elective, which maybe could have been a non-elective, I've got my terms, could have been elective really become non-elective because the risk has changed. You got to monitor physician compliance. All of our clients, of course, will do the right thing, but many will not. And if you are in a facility and you care about that facility, then while I said that if a physician fills out that form, you'll be protected, if they don't, you won't. And also, if it's absurd, like a cosmetic procedure, they can fill out all they want. They're going to have expected you to at least have done some sampling. So monitor that to the extent you can. And then also, you know, that goes to really the communication between the different institutions, that you may want to move things to venues. I know last night I was on a very interesting conversation about using space between two disparate organizations in a more efficient way to move at-risk patients out of the hospital. So continue those discussions, which I think could really be helpful. Okay, so we have now gone through the executive order and operationalizing it. Before I look at a question box and see what else is there, we're going to keep pumping these things out as it changes, but we kind of need all of you out there to keep sending us your ideas about what you want to hear about so that we can make this at-home learning experience worthwhile. Okay.
I wanted to raise one administrative point. We will be sending out a tape of this presentation as well as a copy of the slides to everyone who is attending. That'll be later tonight.
Right. Okay, so let's take the first question. And don't worry about asking questions. We will not identify unless you tell us in the question the person's name. But somebody asked, how are accrediting agencies handling an ASC that is being converted for COVID-19? Stacy?
I mean, I think the accreditation agencies are going to be on board with everything that is necessary to address the current emergency. And in addition, the waivers that have been and executive orders that have been issued by the state government and the federal government will cover you with the accreditation agencies. They will not cite you for something that has been specifically authorized by the government during a state of emergency, where they won't stay in business.
Yeah, and what I would also say is that I would not worry at all. I would not worry at all about the accreditation. The accreditation agency that's going to do something to you because you changed your platform, we will give you a heavy discount of your fees to argue that one because that would be really incredibly offensive. So I wouldn't worry. All right. The next one, I'm having trouble really reading it. Doing interventional pain procedures, I think, is that the same? Doing elective procedures in the office, surgery center, or hospital? I think I'm going to try to fix the question. I think what you're asking is, does it matter if I'm doing the interventional pain procedure in my OBS or in my ASC or my hospital? Is it the same scheme that you have to go through for determining whether it's elective? And the answer is yes. Okay. Next one is pretty easy. Will the slides be available? Yes, they will be. Can you provide the sample phone log via email? Yes, you're going to get a link. Our IT staff and our director of marketing, I want to give them a plug, are working very hard, and all that stuff will be out, if not tonight, then first thing in the morning, and it will have all of the sample logs and slides. Many ASCs have cut down on hours due to decreased volume. I can't read the rest of it. Can you?
Yeah, I can. They may also not have a clinician on site if there are no patients being taken care of. Patients should be instructed to contact their surgeon's office, who should be making the decision about their care. Right. You should instruct patients to check with their physicians to make sure that their procedures are going forward as scheduled. That is a good point.
Okay, can you show the slide with the form declaring that the procedure is not elective? Yes, you're going to be, you know what, the good news is that our director of marketing is on listen only. We're going to get this out to you tonight because I swear I can't listen to her yell because I realize this is going into effect. You need those forms. So yes, we will be getting those to you. Okay. Stacy, how about you take the next one? Can you again explain the timeline for compliance for the executive order?
So it is not very clear. And I'll tell you everything that has happened, and you can decide the risk for yourself. On Saturday, during his daily briefing, Governor Cuomo said that he would be issuing an executive order that as of Wednesday, no more elective surgeries in the state of New York. That executive order was published on yesterday, on the 23rd, was published yesterday, and it didn't exactly ban elective surgeries. It said effective immediately, the Commissioner of the Department of Health is directed to issue a directive banning elective surgeries. A couple hours later, the Commissioner of the Department of Health did exactly that. In that directive, he says that by the 24th, hospitals have to do a whole bunch of things, come up with a COVID-19 plan, how they're going to increase beds, blah, blah, blah. It doesn't say the date by which exactly that ASCs, OBS, and D&T centers are supposed to stop doing elective surgeries. So it's a little unclear, although I do believe that the efforts of the hospital and the ASCs, D&T centers, and OBS are supposed to go hand in hand. We therefore recommend that you stop doing surgery after close of business today, elective surgery. As we said earlier, if you have people prepping or doing something for tomorrow, that it really doesn't make sense to cancel something that is on the cusp of being elective, there probably is not a significant risk of doing that procedure tomorrow. You certainly shouldn't be doing elective surgeries after tomorrow. And we think a more conservative approach would be to stop today if you can.
Okay. By the way, a lot of you are asking for specific procedures. Are they elective? They're not elective. You're gonna need to call us because one, I don't want to give advice like that out in the ether. And is X procedure elective? That's going to determine, again, think about the definitions that Stacy went through, which is, it's not just the procedure, it's the question of the patient, their health, the environment you're bringing it into them, their particular need for it. Think of it this way, just to give a gross example. A colonoscopy could be you got to get it right now because you're bleeding, or it could be you just turned 50 and somebody recommended that you get it at 50. Same procedure, different situation, different context. So I'm being a typical lawyer and call us. Okay. Let's go to the one, Stacy, I lost on tier 3A, 3B. Somebody wrote tier 3A and tier 3B does not list ASC in the locations. Are ASCs excluded from doing these procedures? So
no. I think the creator of this form, which was a physician, just said that he was listing the place that these types of procedures are often performed at the hospital. It wasn't an edict that these procedures can only be performed in a hospital. This is just merely guidance to give a sense of the spectrum of really elective versus trauma, like really necessary. It's not saying that you can only perform those procedures in a hospital.
Okay. Thank you for the person who corrected. We were misunderstanding your question. The question about agencies was referencing requirements to report to oversight agencies, not concerns about compliance. Who has to be notified if an ASC is converting to support COVID surge needs? My understanding, and by the way, I know there's a lot of healthcare people on the line. If you take a look at the full order, we obviously, and probably should have said this, we were just looking at the part that dealt with elective procedures. It is fascinating, and years from now we'll study how government can change things when they want. But there are a lot of healthcare rules in there which we're still digesting. So, for example, a physician's assistant no longer has to be supervised. Okay, so there's a lot of changes that went on. I believe that if an ASC is changing to deal with COVID surge needs, that's going to be in connection with a hospital surge plans. Those surge plans are all being submitted, that's why you should talk to each other, to the Department of Health, and therefore I think I would deem that to be sufficient notification.
And I
these
just want
are
go ahead.
No, I'm done.
Okay, I just wanted to make one teeny little correction. So as people don't get confused, the governor issued 2 executive orders yesterday. One is about these surge plans and the ban on elective surgery, and the other one is on the licensure issues for PAs and everything. So if you're looking for both of those things, they're in two different executive orders.
Okay. Somebody asked an HR question. May staff refuse to report to work about repercussions without repercussions? So again, there'll be separate things on HR, but that's a super loaded question because you'd have to know the reason that they're refusing. Does the person have an underlying health condition that may warrant an accommodation? So those rules don't get thrown out. And medical facilities, even though they are essential, are still supposed to make efforts to minimize staffing levels. So putting all of those issues aside, let's assume it was, I'm gonna make an absurd assumptions. It's a healthy person who would rather sit home and watch CNN and just doesn't want to come in. They're refusing. That person could be fired or laid off, right? Now, but I do not do that until you consult with your HR attorney or us, because it's a very nuanced fact pattern that may change. Okay, so so I think that a lot of the other questions or people are asking is about what's elective. So if you look at the slides, Stacy and I, our names are there, Jim's there too, he doesn't get to duck out. So feel free to ask us whatever you want. If you want to log into that reimbursement thing, if there's still space, I think there are over 1,000 people now, you can get onto our website and you can log on and register. If you have questions as this goes, we're here to answer questions on contracts, HR, healthcare, and anything you need. And again, I'll end with where we began. Stay safe and stay sane. Take care.